morning, everybody. Welcome to the International Pilates Therapy Exercise Conference. I'm Gill Cummings-Bell, for those of you who haven't met, so I'm very pleased that you've been able to join us. I know a lot of you are joining us at another time, so we are recording all the sessions, so welcome. You've joined the first session with Alex Drummond, who is our clinical director and lead physiotherapist. Alex runs one of the largest physiotherapy clinics in the southeast of England that is multidisciplinary, and he will explain an awful lot more about that. I thought this would be a really interesting session for all of you because Pilates therapy is growing and growing, and I thought it might be interesting to take a physiotherapist's view of where they felt there was a place where we could work together.
Okay, welcome guys, good morning. And may I say, because I won't see you again afterwards, Merry Christmas. My name's Alex. I am the clinical director for Drummond Physiotherapy. And within Drummond Physiotherapy, we've got multiple different types of services with as a practice. From general physiotherapy and sports physio to biomechanics, orthotics, pre-post operative rehab, as well as the Pilates element and wing to what we do, and that's an ever-growing process. And you know, asked me not so long ago, not months, but a few years ago, about Pilates, and my answer would have been quite different as today. Things grow, things progress. As therapists, we need to embrace what's out there and not fight. Not that I ever fought it, of course, but it's about bringing in as many tools as we can to the clinic to offer our services to every individual that walks through the door that need our help. And so if we can have as many tools in our toolbox, it makes sense that we can help more people in many different ways. We don't use the tools all the time, but that's how we build the clinic. And next year, something else will come along and we'll make our services a little bit wider. So for me, we're ever reaching to produce a bigger service network for each individual that comes through the door, whether that's to classes, whether that's to one-to-one. And within that, we build a specialist therapy team. My specialism is in biomechanics and movement correction. And within that covers so much of what I do on a daily basis. Most people come in broken because the biomechanics are faulty and they can't move properly. Okay. And so really that's kind of where I am within the clinic, and I control the team within that, and we develop and morph the team to follow trends, science, research, as well as all the anecdotal work that we develop within clinic and listening to other people, you guys as well.
Yeah, lovely. So, well, welcome, Alex. We're very pleased to have you along. So, my first question, which I want you to answer for us, is why you believe there is a place for a physiotherapist to work alongside a Pilates therapist or a Pilates specialist in some nature. Why do you believe there's a link between those two?
I think that you coined it there, really, is that I like to see that everybody is speciality in their own right. And for me, you said Pilates therapist and corrected or added Pilates specialist. Increasing an individual's knowledge is absolutely essential to be able to produce the right outcomes. Within the clinic, we offer a multidisciplinary approach, as I've talked to before. And within that, we must have as many tools to service as possible, already mentioned. And within that, the specialities must form. And as a physiotherapist, I like to think I can do lots and lots of different things. But there's times when we can't offer the right speciality for the requirements of an individual. For instance, if I need someone to go to change their medication, I don't do that. I send it to a GP. If someone needs a surgical procedure orthopedically or gastrointestinally, I can't do that. I send them off to the specialist. And from there, we develop then the requirements for different skill sets. And within that now, we see an upgrowing ability. And what's nice within Pilates that's different to quite a lot of the can I use the word fitness industry and Pilates together? Because that's where they kind of sit alongside, is that we start to see an increase in the ability of an individual and the want to learn more and produce different effects. But there's so many people now that are moving and evolving into ways where they are understanding more about the body. You know, it's not a case of just learn some exercises and produce Pilates now. It's understanding the anatomy, understanding movement, understanding the ability to produce a different outcome based on a series of assessments.
And often Pilates teachers are worried about the fact, or physiotherapists are also worried about the fact that they think they can do the Pilates elements themselves, or Pilates teachers often don't feel that they can approach a physiotherapist because they're not as qualified. But listening to what you're saying, in your clinic, you refer to Pilates teachers on a therapy basis because of the fact that your physiotherapists aren't necessarily experts in that type of exercise. So would that be the same outside and across the board?
Yeah, I'd hope so. In terms of the referral, I mean, if the physiotherapist is trained in Pilates and they can deliver that within their therapy, absolutely fantastic. But there is a role delineation where time with patients is quite limited, and absolutely we then refer to our clinical Pilates team to offer the care either towards mid-late stage of a rehab where we'd pass a patient over to then do all of the referral handouts. We'll talk about that in just a little bit later. But also early stage. Sometimes we need that activation of the body to be occurring a lot earlier. Certainly when the pain is there and we're trying to mitigate pain. So right across the spectrum of the rehab program and the time spent with an individual patient, we can pull in one of my team or the like. If you don't have Pilates within a physiotherapy clinic, then you work closely with people that are close geographically to you or geographically located towards where the patient lives, because we get a lot of referral from quite far afield.
Okay. What processes do you need in place as a Pilates specialist in order to work with a physiotherapist and take the benefit of that referral?
Yeah, the Pilates, the referral process is essential. If we don't have that process in place, then we're kind of falling out about ourselves and not really giving the Pilates teacher much of a chance or an indication. The process defines the exact requirements for referral, and within that we have a good referral form that covers the goals, expectations of the patient, the goals and expectations of the Pilates teacher or therapist, whatever you like to call this person now. It sets the handover process for what is the condition, what are the program goals, what are the limitations that the Pilates teacher has to abide to, and when to refer back to the therapist. So there's some really good definitive boundaries that a person must then stick to in order to work closely with me, as an example. So with my guys, I will say, right, okay, this is what I'd like you to work on. Go and do that. Do your own assessment, but listen to what I've referred to as well. But I don't want, for instance, any rotation for the first X until you refer back to me with some notes, and then we can progress that. So it's really about having a really close contact with therapist and therapist, okay, Pilates therapist and physiotherapist, and the ultimate goal is then you have that communication channel open, and it's all about the individual client. Okay, so there's that triad of people, client in the middle, therapist working in synergy to look after that individual.
And you said you have a referral form to pass between the two of you, so that's quite an important document, isn't it? It's not a big document, it's not one that requires 3 hours of writing. It's a very quick handover document, but it's quite a key document, isn't it? It's got some very key questions on it, like you were saying, that, you know, what's the condition, what do you want to work on, what must you not do, and when must you refer back, and are there any flags, any yellow or red flags?
Yeah, absolutely, and that worked particularly well. It sounds like you know the form quite well.
Yes, having it, and I think that's quite a useful thing to understand, that there needs to be a quick process, doesn't there? Because you guys see patients back to back every day, so all of your clinicians are in clinical practice on half-hour appointments. What they don't want is a long process, and that's often something the teacher finds quite difficult to get people to actually refer. Through that process. So a quick, simple form is a real easy answer to that, isn't it? So we can share that form.
Yeah, and it really helps. And then the notes come back the other way as well. And so as the program progresses, then milestones are achieved, functionality is changed, and as a result of that, we can then kind of have a conflab again about how an individual can progress or come back for an appraisal and continuation of treatment. I never work in isolation, so I'll very rarely will I, until it's absolutely late stage where the person is rehabilitated and then moving into the preventative lifestyle, very rarely will I not be treating at the same time. And so there's that push-pull from therapy room to Pilates room to produce the overall program and wellness program for that individual.
So quite often they're running side by side.
Yeah, exactly.
And you're still overseeing the two programs.
Yeah.
Yeah, excellent. So what conditions do you typically refer out to a Pilates therapist?
Biggest really is that non-specific lower back pain is what's causing the back pain, where all scans are clear. There's no disc problem. There's no spinal bony pathology. There's no real highlighted neurological reason as to why someone should have back pain. So that's kind of a biggie, really. And when we start to look at that, we're looking for to understand someone's immobilities, someone's lack of skill for movement, someone's lack of endurance, strength, and if we can establish all of that, then, you know, hitting from a Pilates element, certainly the early stage of mobility skill has a massive upskill for that individual to start moving better, where the neurological system starts to change. So really non-specific low back pain is a biggie. You guys deal with that loads and loads, I think, already, because of the open referral network of a GP just going, well, you've got back pain, go to Pilates. And that sometimes I think is quite scary, because you know, the GP moves you away from the GP and says, actually, I've dealt with that patient. A little bit of a sweeping statement. So if there's any GPs present, apologies. It is a bit of a sweeping statement, but so many conditions of back pain related issues are sent to Pilates, and whilst that's nice for the Pilates world to have bigger numbers, it can be quite scary and off-putting for some of the teachers who actually many times aren't on their own able to deal with the individuals. So yeah, we've got to be a little bit wary of that whole referral process. More restrictive and serious injuries, which involve skeletal issues, so where we may get some pars defects, some fracturing, some facet joint issues, that type of things, then more close guidance can be given, where there are absolute delineations of limitation for a Pilates therapist to do. So there's some more conditions a little bit more serious that we pass over. But then that depends then on the skill set of the individual person that we're referring to as well. So the more experienced Pilates therapist would get something that would be a little bit more complex, because they can appreciate that, they can limit themselves, they can adapt based on their knowledge. We then get also the people and refer to the Pilates therapists where they don't have back pain, they just have poor stability, poor control, and that's not just stability around about the trunk pelvis, it's a lack of stability from the ground and foundation upwards. So actually recreating a better movement pattern, recreating a better movement skill and endurance and strength pattern can really help the runner, can really help the team sport, court sport, pitch sport player. And so many times, if someone comes in with a lower limb related injury, that we can then pass over for Pilates at the same time. And that's something that then is concurrent within their training. You know, we've got runners that come in that benefit hugely, that don't have a problem, but don't want to have a problem, benefit hugely from a lot of the dynamic type work that's done within the Pilates field. So for me, it's another tool. It's another form of conditioning. It's not the only form of conditioning that we use, and we can't expect everything to be done via Pilates, and that would be totally wrong for that to be expected. But there's a time and place for the fit. So many athletes that we have come into the clinic are dynamically very, very good performers, but statically very poor performers, and that opens themselves up to a huge amount of potential for them to live on this precipice of excellence in performance versus being injured. So many times we slow an individual's movement down, we start to open up their chinks in their armor, if you like, their areas of movement, and so yeah, that is another one really, is that the athlete that is a high performer or a good performer or a continuous performer isn't always the most stable. So many times that is a big opening to pass over to the world of Pilates, movement correction, and that side of things.
Excellent. And you know, I hear a lot of what you're saying, and you know, movement comes into a lot of what you're saying, and also linking that, as you quite nicely do, as a phrase to Pilates. And I think that's where Pilates teachers really believe that, you know, we're all movement specialists, aren't we? We come together from those different fields, which is great. So when you hand over a patient or you refer a patient, what commonly are the things that you would request a Pilates therapy teacher to work on, as in physically work on within their programming?
I keep on talking and mentioning about the mobility skill, endurance, strength, facets of progression of an individual, you know, and so many people in conditioning, and I'm going to put Pilates in conditioning, don't work at a low enough level for long enough, and that's not just in Pilates, it's across the board. You know, I've done a lot of work that have sat side by side, not attached to, but high level British and English sport, and it's right across the board. You know, people are trying to lift too much because without the prerequisite movement capability and stabilities. So the biggest thing for me is for everybody that I send patients to do their own assessment, come up with their own goals, listen to the limitations and governance that personally I give or the therapist would give, and guide with that. And that starts with mobility skill. If you can't move the body selectively through the unconscious to conscious components, then ultimately at the end of the day, the individual, when they go away and they live their life, whether it's activities for daily living or their activity of walking and just walking the dog, or going out and doing an easy cycle, or going out then to the spectrum of I want to run a 5K, a marathon, an ultra marathon, a sprint triathlon, an Ironman triathlon, whatever, a cross-country ski race. If you can't move well, you're not going to perform well. And performance is that big, long line, isn't it? Performance doesn't always mean that you're going to be competitive. The performance is, how do you perform on a daily basis? And if you're performing on a daily basis and you have aches, then you've got to mitigate that by understanding what's causing those aches and working on that. So the Pilates teacher, to come back to it, must be able to have that ability to look at an individual and see what isn't working and address those things by mobility skills, endurance, strength, in the right order. Sometimes we can marry them side by side, certainly mobility skill, endurance. Yeah, absolutely. So it's looking at that. The biggest things that we see from a clinical side would be really the lack of ability to segmentally move the body, the lack of ability to segmentally move the spine. So lumbar pelvic rhythm. And when we look at that lumbar pelvic rhythm, we've got to look at what the hips can and can't do. Can the hips fully flex, extend, internally, externally rotate, abduct, adduct, and concurrently left to right? Can the pelvis anteriorly tilt based on the function of the lumbar spine and hip joints? Can the lumbar spine articulate through a nice fashion, and incorporating that with thoracic? I've got to say, thoracic spine is the biggest enemy for me when I'm looking at movement correction, is that thoracic spine is a big indicator to head, neck, shoulder postural issues, as well as fixing and making the lumbar spine work in an aberrant way. So if we only go, you can't move the pelvis well through anterior, posterior tilt, rotation, lateral deviations through frontal plane, don't just go lumbar spine and pelvis needs that work on its own. Think of the global picture. And that's where I try and get my therapists and my Pilates team to look at the bigger picture. Don't just look at the individual thing that they're not doing. Get the big picture and understand what an individual can and can't do from really big movement appraisal. And so to that extent, you know, our assessment isn't just in a small portion for the Pilates team, it's looking at big movement. And when we look at big movement, or if we don't look at big movement, we're missing a trick. When we look at big movement and we start to address big movement issues, we sometimes see that the finite areas of fixation start to move on their own. And so that's really, really essential to understand that side of it. So my encouragement, to go back to your original question, is really to look at global before we go local. And if we don't go global first, then I want to know why. And that really is essential for me. So does that answer that question?
Yeah, it does. And we have a term that we use in our therapy training, which is look for the elephant, not the mouse, to start with. If you're looking for mice when you're watching somebody's body, you're almost stepping out of remit, because you're getting into real detail of work that we don't do. But if you look for the elephant, the mice will follow along, if that makes sense. So it's kind of saying the same thing, aren't you?
Yeah, exactly that. You know, don't try and fix all those little things without looking at the bigger picture. Yeah, because some of them will fall in place. And then down the line, that we may need to look at different things. We may need to look at the thoracic spine individually. We may need to look at shoulder joint restriction because there's a subacromial impingement as a result of a rotator cuff problem. We may need to look at dorsiflexion. Probably would if there's a restriction there. But what I'm saying is that look at the big picture, see the big movement issues, and then deal with those and gradually hone in on the smaller stuff.
Okay, great. And where do you feel the boundaries are? Because this is often something people worry about. And I know we've had experience in the past of people overstepping the boundary with working with a primary care practitioner. So I think it'd be helpful to understand where those boundaries are, because that gives everybody confidence to work together. So primary care practitioners, you have confidence if you know Pilates therapist teachers understand where the remit fits with yours and where that boundary fits and where you have to refer back.
Yeah, I think the boundaries are absolutely essential. Without that, I have clinically, I have a card system in the clinic. So with a patient, if a patient is asked to do something and they don't do it, and they don't really give a valid reason as to why they've not done it, I give them a yellow card. If they don't do it twice, then they get a red card and they get given another therapist number somewhere within the town that we live, and we won't have them back in the clinic. A similar thing really is if the bounds of an individual therapist are overrun, there's a point at which I won't work with anyone outside of the clinic if they don't toe the line. So the key thing is for anyone doing any work on referral is listen to the guidelines that are posted by the therapist, because the therapist is the primary practitioner in this case. If in doubt, ask. The big thing that I would say is never guess. Yeah, if you're not sure, don't just guess doing something. Research, ask first as a primary, the referral practitioner. And if the referral practitioner and you together can't come up with an answer, then that must be then referred out a little bit deeper. So if that was the case for me and I'd done some treatment, I'd referred to you, Jill, for some clinical Pilates work, and we weren't getting the results that we wanted, my next stop would be to speak to my resident orthopedic consultant, back consultant. And so, it's about just understanding limitations, respect of the referring practitioner. If someone refers to you, don't lose communication with them. Don't go, thank you very much, goodbye. Think that's a building relationship. And just because we have loads of services within our clinic, it doesn't mean that we don't refer outside of the bounds of our team. And we do, and it really does depend. If someone's traveled an hour to see me, they're not going to come for a half hour, 45 minutes Pilates session twice a week or once a week indefinitely. We need to try and link with people that are a little bit distant outside of our kind of inner circle, if you like. But I would say is, if in doubt, ask, don't guess.
And that's a good encouragement, isn't it, for Pilates therapists? Because although you have a Pilates unit within here, as you say, a lot of patients come from elsewhere. And actually for if you want them to go regularly to a Pilates session, you're often linking, we've got many other therapists that you link with outside that live in those areas that your patients come from, that you would carry on their Pilates program there. So there's lots of opportunities not to link just with physios in your very local area, but maybe physios who are wider, because often people go to a physio where they work, don't they? We have people who work perhaps here corporately and come to physio in the day, but actually live London and different places, and they travel for quite a long time. So that's a good encouragement really for people to link wider with a physio team, isn't it?
Yeah, and then when people do come from further afield, we do really encourage the Pilates teacher, because we're just talking about Pilates today, it's not only Pilates that I refer out to, but the individual person looking, or the individual therapist, trainer looking after that individual, to communicate with us, or at least us communicate with them to say, look, this is what our findings are. It might be a one-touch referral because you're way away and there's a therapy team that can look after that individual where you are. But the key thing is to make that communication. I surround myself with loads of people, as I alluded to at the beginning of the session. I've got my clinical team that sit within me, within the clinic. I then have my GPs that I like, and I get responsive to how we are. Now, we're in a private practice. We don't feature in the thought process generally as a physiotherapy practice under the banner of any GP and NHS GPs. And the fact of that is because we deal with the apparently healthy adult that is in a little bit of musculoskeletal trauma. So our speciality is, at the moment, is musculoskeletal physiotherapy. And so we've got to try and link with people and GPs that we find that work to us. And generally they're the GPs actually that have been into the clinic and see the benefits of the wares of the clinic themselves. So
yeah, or they're GPs, aren't they, who are active themselves, actively involved in sport or exercise, or because that is often a barrier even for us, is to get in touch with GPs, because they're also very busy people, and there's a big difference, isn't there, between NHS physiotherapy and private physiotherapy, in so much as, you know, the length of time when they get to see a physiotherapist, and they're less likely, an NHS physiotherapist is less likely to refer out to a Pilates teacher, I would think.
yeah, and the things in with the NHS is we know the demands on the NHS are absolutely immense, and the more demand placed upon the general NHS load, the more is then passed to the physiotherapy side of things, and therefore time changes. The ability for the therapist within the NHS to produce what I think is an acceptable outcome is quite limited. So the hands-on elements of physiotherapy within the NHS is very limited now, and the time spent with the speciality of movement correction is quite limited. So we kind of, from a private practice, need to be mindful of that, and work to embrace that. But it's making those links with all of the people. So the rest of the people around me would be personal trainers, Pilates teachers, outdoor fitness teachers, because there's more and more of those. Then looking at consultants, foot and ankle, knee, hip, spine, shoulder, arm, wrist, and all of those are the network that I have the ability to refer to or be referred from. And you guys can be the same. You know, if you haven't got a team and a circle of people around you to help you facilitate your current client base, then kind of missing a trick a little bit. So spread your wings a little bit more, and link. You know, if you want to go and see some back surgery, you know, once COVID's calmed down a little bit, link with your local spinal consultant, link with your knee consultant, your ankle consultant, and say, look, this is what I do. This is where my speciality is. I want to broaden my education. Can I come and see some surgery? And go and watch it, the intricacies of it, look at the body and see, you know, really when we look at an anatomy picture, if you've not done any cadaver work and you go into a knee or you'll see inside a spine, it's like, God, I don't recognize any of that, and because it's just a massive nothingness. So yeah, link with more people, understand what they can do, let them know what you can do, and you'll get a better outcome and a better relationship with that individual.
What's the best way to approach somebody like yourself, a physio in private practice, in order to get referrals?
Be confident and don't bullshit, but be confident with your abilities. If you're not confident with your abilities, then the people that you're going to chat to aren't going to, I wouldn't entertain. So if someone came to me and their anatomy was particularly poor, and their appreciation of the body was particularly poor, then I wouldn't even entertain someone coming to me. So, you know, the key thing for me is be confident in what you do, portray what you do in a really, really professional and positive fashion, be able to talk about what you do in depth, and then an individual therapist, whether it's a physio, osteo, chiro, will have a lot more confidence in what you're talking about. But because there's thousands of people out there, there's thousands of different abilities, and we need to be really mindful of that and demonstrate your abilities. You know, when you're linking with someone, there's a lot of people out there, physios, that have never tried Pilates. Get them into a class, get them into a one-to-one session, get them into an assessment and say, look, this is what we would get, or you would get if you referred a client. This is the assessment that I would do prior to doing any movement or any work with one of your patients, and then run them through an assessment process. And if you don't have a good, thorough assessment process, and you're not confident with it, then build one. So they're kind of big things, really. Be self-confident, believe in your abilities, sit yourself on the same level as everyone else. So me, 25 years in the industry, a fair amount of time, sitting next to spine, knee, hip, shoulder consultants, ankle consultants, GPs, specialists in X, Y, and Z from the musculoskeletal side. Sit yourself up on that line. And if you can't sit up on that line, then ask yourself what you can do to upskill yourself to be able to sit in parity to everyone else. Because, you know, as much as Gill and everyone says that clinically I'm a little bit, was the word scary? I'm not. I'm passionate about what I do, and I want the best out of the individuals. So if someone comes to me and they are a little bit washy, then they're going to get washy back. So confidence in what you can do, parity within your confidence of where you are and the level you are, and then you'll get a good response. And I really firmly believe that there's space out there for so much more work on the musculoskeletal side that you guys work in.
Just for whilst we've got 5 minutes, has anybody got any questions at this stage they want to ask Alex? Feel free to either put them on chat or unmute yourself and ask the question about things that maybe relate to you and physiotherapy referral. Feel free.
Ask a question.
Yes.
Oh, yeah, Michael.
All right. How do you handle a client that comes in that's seen several practitioners and is kind of frustrated and from a Pilates teacher point of view that we don't have somebody definitive to refer to because they've seen so many? How would you handle that client coming into a Pilates environment?
Into a Pilates environment or into a clinical environment? No,
into a clinical. Like, so I have many times clients come in and they don't have a referral, but they've been seeing so many physios and nobody knows what's going on. Yeah. Basically. That's
into a Pilates one. So let me turn it on its back a little bit and say, if that individual comes into me and they've been to see, and they've got back pain and they've been to see a spine consultant, they've had MRIs, CTs, X-rays, they've had cortisone injections, and it's not really touched it. We've got to look. All I'll do to start with is get to look at the big picture. And with the big picture, we get so much information back. And for those that have sat under Gill for any teaching, we call that the diagnostic eye. We have that ability to look at someone's movement and just go, let's keep it really simple and start to change some of the small tokens that we see globally to do that. And give that back to your question, exactly the same. You guys are movement specialists. If you can't spot something that's going wrong from general biomechanics, then we've got to ask the question whether more view and training needs to be uptaken. So increasing your ability or being able to identify someone's movement errors would generally, Michael, start to achieve a change within that.
I guess my question was more professionally, would you expect us to refer out to who we're working with if it's not clear, or would you say in that environment it's okay to do what you just said, to start looking yourself professionally?
Yeah, it depends on what they're coming with. So if they're in absolute devastating pain, then absolutely refer straight away.
Yeah.
If they're in like this non-specific issue that's not being diagnosed through imagery and all of the things that I've just alluded to, then do your stuff, get people moving, because so many times that I get people in where they have had no effect from treatment, they've not had some of the basics done, and it goes back to how do they move, what's their mobility like, what's their ability to segmentally move the body like we can move our fingers, with great dexterity. We must be able to do that with lots of parts of the body, all of the body. And if we can't, then the result is that something's going to lock down. We're going to get a compensatory set of patterns that then put us into the position that we are. If we can identify with that, then we can take people out of that. But what I would say is, give it a short period of time and start to see if there's any form of change. 3 or 4 sessions, you should start to see some changes. And within that 3 or 4 sessions, what I might say is keep a diary. Have the client patient keep a diary of a daily incidence of good, bad, or indifferent comments, and you'll start to see patterns. Because coming in and saying a week later, this is how I was on Friday. Oh, I can't really remember Saturday. If you've got a diary, it's like boom, 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 you can see a pattern. After the last session, I had 2 days where it was really good and things changed, and then it started to creep back. So yeah, common sense prevails when someone comes to you who's been seen with many practitioners and had no results. Pain is an indicator. Really, really, really important that I would then refer out if it's bad. But if it's this general non-specific issue, then yeah, I would, as long as you believe in yourself and you're not guessing, because it comes back to that guessing again, I would look at your skill set and go, I can create movement. And as long as you stick to some guidelines and maybe look at flexion extension first and not rotation or lateral deviation, and build movement on that, and then gradually bring in small movements that accompany all sagittal, frontal, and transverse planes gradually over a period of time, and you start to see results, carry on. If you don't see results, refer it out at that point. And that's what I would say. We can't belittle any people that they've seen in the past. We must embrace where they are now, and then encourage them to kind of make the changes in what they should do. And all of your programs must be given or backed up with a home exercise program. Yeah, and that must be the case. It can't be a case, come and see me twice a week and we'll sort your issues out. You must do a home exercise program to work on the first, second, third priority goals of what you see within your program, within your assessment and your session.
Thank you for that. I did one comment though, is when you mentioned about going to watch surgery, two of the original teachers, Kathy Grant and Corolla Trier, used to together go watch surgery. So when you said that, it took me back to how Pilates was originally, where those original teachers were wanting to learn more about anatomy. So it's not a modern thing.
No,
you know, it's actually always been there.
Yeah, absolutely. But I think quite a while ago there weren't as many. And so with not as many, you get a, what is it I'm trying to say? You kind of get a skill set that is there, and a want for more information when it's small. When the industry is a little bit bigger, we get a dilution of all of the things that people did back when. But you're right. Yeah, no, it's not a new thing, but don't be afraid to ask. You know, don't be afraid to learn, you know, and going to understand more. So yeah, it is, but it is invaluable to go and look at that. And then the spine consultant or the knee consultant are like, okay, she can talk or he can talk a good story, and will or may then start that referral process, not just from a physio, but from a consultant. You may already do consultants. Yeah. So yeah.
I think a lot of what you say about confidence is very key, isn't it? You know, having confidence in yourself, and you know, Michael and I have had discussions, and many teachers we've had discussions, and you and I have had discussions about the Pilates therapy world, and obviously we have to upskill, because you know, it's not enough just to know the exercises. You do need to know therapy as well, don't you? You need to understand that therapeutic process. And that rehabilitative process, and that programming that sits behind that. And clinically, you work clinically every day, and you refer to a Pilates therapist. And I know COVID has been quite a highlighter on who could work and who couldn't work. And we had all that thing at the beginning, whether we could carry on seeing Pilates patients and so on and so forth. And I thought it might be useful to clarify with yourself today this concept of clinical Pilates and Pilates therapy, in so much as it doesn't need to be a clinician to be a clinical Pilates session. If that person is under a clinical rehab medical case and you refer to a Pilates teacher, that Pilates teacher working within that treatment plan under a primary care practitioner is working clinically as a Pilates clinical therapist, because they are involved in that clinical program, rather than a Pilates teacher just outside working on their own. So it's the medical case and the medical reasoning that gives it its clinical reasoning. That part of the clinical reasoning is that the Pilates program is of benefit to that patient.
Yeah, I mean, when you look to upgrade, upskill to doing things a little bit more intricate, it's really important to remember that you're still not diagnostic. You know, the individual walking through the door says, I've got chronic back pain. You're not a diagnostician, unless, of course, you are a physiotherapist, physical therapist that is qualified to diagnose. So I'll just say that straight away. The importance of what you just said with regards to a Pilates therapist sitting within a clinical team doesn't have to be in the same building, but it needs to be within the same network. And that's really important as well. Yeah, and you know, going outside of that is that they're really the defining lines. The patient care journey, how you treat someone with an achy back to how you treat someone with a pathological back, has to be quite different. And that, you know, we can't do on our own. So, you know, how you deal with pain is really quite specific. We've got to look at patients differently than those people just with general mobility and stiffness issues. So yeah, really important. You can't work alone as a clinical Pilates therapist. You have to be linked with the medical fraternity, who are like-minded in that musculoskeletal world.
Yeah, and that just gives us all potential growth, doesn't it? It gives everybody a job to do within the program. And one of the things that I think is very clear from what you're saying is understanding that you can be part of that process really confidently and really, you know, have so much work that you can do to benefit a patient, and just have confidence in doing that, but making that link, you know, with people like yourselves.
Yeah, and it's really important. You know, it covers you guys as well. And you know, if you're alone and you're doing stuff and you do some rotation, flexion, lateral flexion, and someone's pain just goes through the roof, and you haven't got any training and medical training or medical support, you're opening yourself up to what now could be, you know, quite a serious investigation into the abilities or occurrences of what have happened. So it's about covering your backsides as well, as creating yourself a development platform to move forward and increase your skill set.
Cool. Does anybody have any more questions for Alex at this stage? Feel free. No? That's great. So that's lovely. Thank you so much, Alex, for sharing your view on how to work with a physiotherapist. I certainly found that really useful to understand that referral process, and I hope for everybody it's motivated you all to see that actually there's a whole world of people that you could work with out there that will really fit nicely with what you do, and enhance your ability to teach Pilates therapy. So thank you all very much. Thank you, Alex.
Thank you. Cheers, guys. Have a good day and Merry Christmas.